Good afternoon, and thank you for joining us today for our 5th Community of Practice Lunch and Learn webinar. My name is Becca Newman, and I'm a project coordinator for the Center for Behavioral Health and Justice, a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. This webinar is part of our Opioid Treatment Ecosystem Initiative, OTE, which is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into the larger community of practice, including all of you who have joined us here today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensure continuity of care to prevent overdose upon release from jail, and connect first responder and behavioral health systems to increase community-based treatment access. Today's event, and those we will hold in the future, will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. Generous support from the Michigan Health Endowment Fund has made it possible for us to offer this event as part of the OTE community of practice. Before we get started, we have a few housekeeping items. First, audio-visual capabilities have been turned off for attendees to limit distractions throughout the presentation, but we strongly encourage you to ask questions of the presenter. You may enter your question in the Q&A box on your screen at any time. We will address questions as time permits during the roundtable discussion portion of the event. If you are calling from a phone, press *9 to raise your hand and ask a question. Today, Dr. Janis Romanik joins us. She is the medical director of Sacred Heart Rehabilitation Center. She obtained her medical degree at Michigan State University College of Osteopathic Medicine in East Lansing. She went on to complete her residency at Henry Ford Macomb Hospital. She is board certified in both family medicine and addiction medicine by the American Board of Osteopathic Family Physicians. She is an established physician in the field of addiction medicine with 15 years of experience and an advocate of medication-assisted treatment programs. She works to educate those through didactic sessions on the benefits of MOUD for opioid use disorder and the stigma surrounding it. In addition to her clinical practice, she spends a great deal of time working to educate primary care physicians and specialists to recognize and treat substance use disorder within their own practice, especially in rural areas where access to treatment providers is limited. Dr. Romanik is an advocate of MOUD within the criminal justice system. She has worked to launch programs within 3 county jails, which initiated and provided MOUD, including methadone, buprenorphine, and Vivitrol, along with therapeutic interventions for inmates with OUD. She works to educate those through presentations on the benefits of beginning treatment for substance use disorder while incarcerated and the stigma surrounding OUD and MOUD in order to improve the inmate's experience and outcomes after release. Thank you so much for making time for us today, Dr. Romanik.
Oh, thank you. So I'm Dr. Romanik from Sacred Heart Rehabilitation Center.
Is it not forwarding for you, doctor?
Nope, it's not. I don't know why. Okay, thank you. So I'm going to speak today on medication-assisted treatment for opiate use disorder, or MOUD. So there's 2 ways when someone comes into the office that we can go ahead and begin treatment. One is non-medication-based treatment. Individuals who typically do better with non-medication-based treatments if they have a lower level of use or a shorter duration of use. But the other route we can go is medication for opiate use disorder. We can look at methadone, buprenorphine, and naltrexone. And I'm going to talk about all three in depth and why they work and how long individuals should be on them. The difference between the three medications, if you look at the graph to the right, methadone is a full agonist, meaning when it binds to the receptor, it activates the receptor completely, your opioid receptor. Buprenorphine only partially activates your opioid receptor, and naltrexone, which is Vivitrol, does not activate the opioid receptor at all. It just binds there and sits there and kind of blocks any reinforcing effects of opioids. So we're going to speak about methadone first. Methadone binds to your mu opioid receptor, so it's a mu opioid receptor agonist, and it's also an MDA receptor antagonist. So the goal when someone is on methadone is to suppress any opioid withdrawal symptoms for about 24 to 36 hours without causing any sedations or intoxication. So methadone, individuals who are on methadone will dose daily, typically once a day, sometimes twice a day, depending on how they tolerate the methadone. Methadone is Schedule II narcotic, and it's also a Category C in pregnancy, meaning that we can use methadone for opiate use disorder in pregnant females as long as the benefits outweigh the risks. The goal in placing someone on methadone who abuses opioids is to block the withdrawal symptoms, cravings, and reinforcing effects of opioids. Methadone actually takes 3 to 6 months to achieve stability. So that's what's unique about methadone. I get a lot of questions about methadone in that people want them, patients on it 1 month and off. Methadone doesn't work that way. It takes anywhere from 3 to 6 months to achieve that stability in methadone. So you have to work on a titration schedule. So you slowly titrate them up, and average dose is anywhere between 80 to 120 milligrams. Classically, we start individuals dose at 30 milligrams. So when we do start them at 30 milligrams, we can only increase them every 3 to 4 days, 5 to 10 milligrams. So that's why it would take up to 3 to 6 months to achieve stability so that individuals are dosing at the appropriate dose. The other goal is we want to correct any biological abnormalities that may be present in the opioid-dependent individual. So how is methadone distributed in an OTP? So methadone is a unique medication. So the only time an individual can write for methadone outside of an opiate treatment program that's licensed by the state and federal government is if they're hospitalized, and then the hospital has to have verification from the opioid treatment program, or if it's used for pain relief and pain management. But individuals, if you were to have someone come to you and say, I'm on methadone because my doctor's prescribing it for opiate dependence out of their office, and it's a primary care doctor or some other type of doctor, they can't be writing for opioid dependence outside of an OTP. They're not allowed to write methadone. So I know most people haven't been into a clinic, but it's very, very tightly controlled by the federal government and state. So every clinic is going to have a physician on site to manage dosage changes and treatment. It's going to have nurses on site during dosing hours to dispense methadone. One interesting fact is that most people don't know that opioid treatment programs, we only dispense methadone as a liquid. So a lot of individuals who are worried about diversion of methadone, and if someone was to get take homes, one fact is that less than 4% of methadone, that is less than 4% of methadone from an opiate treatment program is distributed or diverted. So that means 96% of methadone that you find diverted that's being sold illicitly as an illicit substance or sold on the street is actually coming from the pain management doctors, from the wafer tablets. So you really only see less than 4% diverted from an opiate treatment program. And part of the reason is because we are so tightly, we're strict, we're regulated, and we have to have multiple licensure. And we do operate with a lot of rules associated with our program. We have set hours for administration. Most of the time, most clinics open anywhere between 4:30 and 6 a.m. And then we typically close around 1 or 2 p.m. So we have a set hours for individuals to come in and get their medication. Initial attendance to methadone programs, you have to present daily, which is different than any of the other medications. So individuals who are on methadone, it's a huge commitment to be on this medication. Every single day, 6 to 7 days a week, you need to present to the clinic and be evaluated and to take your medication. So every single time someone comes in, and other way, you have to actually identify them, and they have two forms of identification. They have to present themselves, and then they're going to be seen by nursing every day. They're going to be checked for any oversedation, any euphoria. If they see that the individual is intoxicated, they might not get their medication today. When the medication is taken by the individual, the patient, the nurse has to watch for diversion. So we have different ways to do that, but it's a direct observation to look for any type of diversion, where after they take their medication, they have to speak to you in order to know that they swallowed. So we're really highly regulated in that we have to do direct observation for each dose that goes out. And also, you can't actually have any take-homes in methadone for the first 90 days of treatment. So individuals have to present daily to the clinic for at least the first 90 days. So yet again, it's a real structured program, and everything is right on site, which is very nice. So you're going to have counseling right on site. You're going to have your medical service right on site. And most programs, such as my own, or Sacred Hearts, they have other programs in there. We have peer recovery services within the same program. We're going to have things like we have a primary care physician that comes in once a week to do any evaluations that if they don't have a primary care physician. We can have services such as vaccination clinics at the center. So it's kind of like a one-stop shop. You come in and you can do all of your stuff right there, but you are attending daily for the minimum of 90 days. After 90 days, you can earn what we call take homes, which means you can come in, take your dose for that day, and maybe earn the next day's dose. We would give that to you to go, so you don't have to present the next day, but you have to be sober and you're not using any illicit substances for the first 90 days in treatment in order to earn your take homes. And then it's still very regulated in that you only earn one take home the first time, 2 take homes after another 90 days, 3 take homes after the next 90 days. So the most you can earn at our clinic typically are weeklies to 2 weeks, but the federal government allows monthlies, but we don't have anyone on monthlies because we like to check in on them. Another way that we decrease on diversion is that we do callbacks, meaning if you are someone who gets a week of take homes, that we can at any point say, okay, you picked up your medication on Monday. We might call you on Wednesday and say you have 24 hours to present with all your medication and to show us that you're not selling it or diverting it. So then those individuals have to show up at our center in order to present those take homes, and those are done at random. Also, we do periodic urine drug screening. They're all observed by camera or in person, and we do that a minimum of twice a month, but sometimes weekly. And then the last thing we do to help minimize diversion and also make sure that the individuals are safe to get methadone is something called MAPS, which is the Michigan Automated System, or your PDMP, your drug prescription monitoring systems. And we can do that, and we can see if individuals are getting prescribed some things like hydrocodone or benzodiazepine from other physicians. And then we actually require individuals to have releases of information so that we can reach out to those prescribers, because methadone from an opiate treatment program does not show up on any of the MAPS or PMDP reporting. It doesn't show up in your prescription drug monitoring. It's not entered into the system. So being that it's not entered in the system, that prescriber might not know that that patient is on methadone. So we want to make sure that every provider knows, because we want to be prescribing safely and we want to work together. So if someone's having surgery, they can say Surgeon X is doing my surgery. I'll be getting a small prescription for pain medication after the surgery. So we'll get a release of information so that we can coordinate care. And that's a really important piece. You have to coordinate care in order to make sure that the medication they're getting is safe and that, it doesn't interact with the medication that you're giving. So we do require releases of information. So what are the pros of methadone? So it's a very structured recovery environment. As I explained, everything is kind of a one-stop shop. Everything is within the center. And we have a lot of checks and balances. We have medication and therapy at the same place. We do frequent monitoring daily to begin with, and then it's slow. After 90 days, it can decrease. Individuals on methadone have a decreased risk of intravenous drug-associated diseases. We see decreased criminal activity, decreased overdose risks, improved family stability. There's better pregnancy outcomes. So even though we do know it's a category C, meaning that we prescribe it because we believe the risks outweigh, or the benefits outweigh the risks of being on methadone, one thing that you do have to counsel pregnant patients about is neonatal abstinence syndrome. There's a long track record of efficacy and safety. There's a reduction in other drug use. And the goal of being on it, we also want to reduce relapse, but we want the methadone maintained patient to be able to work and function normally at home and at the workplace. Some of the cons, the restriction in time and place. So like I said, it's a commitment to be on methadone. You have to really need to be on this medication to commit to such a structured environment to be able to come in every single day only during this specific time frame. So there's a lot of stigma also about methadone. So one thing that I talk about is how do we know which medications an individual should be on? So I like to say methadone is kind of one of the medications where you've tried other things and nothing else has worked. So you might have done at the beginning of your usage, you might have done maybe detox and residential, you might have tried a Vivitrol shot, or you've been on Suboxone multiple times, but none of those things worked during your treatment. So that's when methadone might play a role. The exception with that is individuals in pregnancy were more likely to put on methadone even if they haven't been on other treatments. But methadone is something that you go on kind of at the end of your, if nothing else has worked for you. So I kind of like to think about it, all the medications as like if you were to walk into a wading pool. So if you're going to first start treatment, you dip your toe into the pool and you say, okay, I've got, detox, residential. Okay, well, none of those are really working for me. So now I'm going to step into the ankle deep water. So I'm going to try Vivitrol. I'm going to try the once a month injection and see if that works. Now, if that doesn't work for treatment, then you're going to go ahead and walk into the waist deep water, which is your buprenorphine products. So those are the Zubsolv, the Suboxone, or the Sublocade. So you try those out, those don't work. Well, I'm going to go to the deep end of the pool, the area I can't touch, and that's your methadone. So we're not going to place someone on methadone unless they've tried other things classically. So we're not going to push, before you learn how to swim, we're not going to push into the deep end. You have to be on other medications prior, or have a history of treatments that weren't successful to be on methadone. Some of the side effects: constipation, increased appetite or weight gain, excessive sweating, drowsiness during stabilization, and hypogonadism. So it does affect the adrenals. So it decreases the amount of testosterone, changes your estrogen levels. So it can affect things like females don't have regular menstrual cycles when they're on this a lot of the times. So all the side effects you see with normal opioids, you'll see the same side effects with methadone, because methadone is an opioid. So when you look at treatment selection, that's when I was talking about the pool. For all the medications, you do have a significant amount of overlap and indications for one form versus another. So you really need to individualize the treatment. So you do that by looking at the medical history. Are they a polysubstance abuse? How long they've been using? Any psychiatric or mental health diagnoses that may affect your treatment? And are they pregnant? You also need to know, do they have access to the medication you're prescribing? So if they're in a methadone treatment center, is there an OTP in the location they're going to be at? So if there's no OTP in that location, it might not be a medication you want to start an individual on. Hopefully, though, if they're presenting, in order to be placed on methadone, they're going to be presenting to an OTP. One place you might run into this is in pregnancy. If an individual goes into an inpatient treatment center, they're going to be started on methadone. So if you have someone who's going back to, say, the UP, which at this second, there is no centers that prescribe methadone, you're going to have to be able to house them down here to continue that medication. If you're going to put them on Suboxone or Sublocade, do they have access to a buprenorphine waivered physician? If they're going to start on Naltrexone, I'll talk about that more. Do they have access to a detoxification center they can do safely prior to starting the Naltrexone? And then a lot of it is patient personal bias. If the person is dead set against a medication and states that they will not try it, you might need to look at a different medication option, because a lot of it is patient personal bias. And if they want to go on a certain medication, sometimes using that medication is better for them because it helps them in recovery, because they feel like that medication will work for them better. So for methadone, we look at those, and that's when I was talking about the deep end of the pools. They have to have multiple failed attempts at abstinence through detoxification residential centers, failed buprenorphine treatment, failed naltrexone treatment. Do they have access to a methadone treatment center that's going to provide that daily oversight. So individuals who need daily oversight typically are polysubstance abusers. They have limited social support, and if they have a risk of diversion, so for example, if you don't want to prescribe them a quantity of medication like you would for buprenorphine, where they go and get their prescription from the pharmacy, then daily oversight of a methadone program might be a better option. And then individuals with concurrent chronic pain. So an individual with chronic pain, you would want to use methadone or buprenorphine on. You don't want to use naltrexone on, because you don't have any other options for pain management if they do need that. So buprenorphine is a partial mu opioid agonist, so it has less opioid activity. It's also a category C, meaning the benefits must outweigh the risk to use in pregnancy. It's got a slow onset and a long duration of action for blocking withdrawal symptoms. So the nice thing about buprenorphine is it's different than methadone. Methadone has to be dosed out of an OTP, that is, so it's got to be licensed to be an OTP, versus buprenorphine can be dosed out of an office-based setting. So it can be written by any doctor who's waivered to prescribe. So it can be written in a primary care's office. It can be written in a GI doctor's office. And that's really significant that it can be dosed out of a office-based setting. So the provider must complete, so it's either an 8-hour training course if you're a physician, or a 24-hour training course if you're a nurse practitioner or physician assistant. And then everybody has to apply for that X designation waiver and need to add it to their DEA license. So prior to this year, that was true. So right now there's a law in effect, or a new act in effect, that states that anybody, regardless if they took the course, can prescribe up to 30 patients now. So that's really, really important, because now more people can start it. If they go into the ER, they can initiate treatment and refer, because you can now carry 30 individuals on buprenorphine without doing the training, but you still have to have that X designation number. So even if you didn't do the training, you have to apply and get your X number in order to prescribe. So it's for year one, your first year of prescribing, you can do anywhere from 1 to 30, and the Support Act increased that so you can do now 100 in the first year if you apply for the designation. Year 2 is 100, and year 3 you can actually prescribe for 275 patients a month, as long as you meet a lot of qualifying factors, which includes some type of relationship with a counseling center or psychosocial support. You either have to have it in the office or a contract with the center that they're providing counseling for you. And the goal really of the Data 2000 Act was to provide buprenorphine in a primary care practice. So that's a positive for buprenorphine. You also see fewer significant drug-drug interactions. So individuals who are on a large amount of medications, whether it's psychiatric medications or heart medications, you see fewer drug-drug interactions with buprenorphine than you do with methadone. The one thing I'm going to mention is concurrent use of a benzodiazepine. So an individual who might be prescribed clonazepam or diazepam or any of the benzodiazepine, you have to do those with you have to actually prescribe very, very carefully, whether you put them on buprenorphine or methadone. The good thing about methadone, you have the daily oversight if they are getting benzodiazepines, where you can see them every day to make sure there's no oversedation, which you don't have that ability when they're on buprenorphine. So previously, ASAM said that, they frowned against it. No one who was on methadone or buprenorphine should be prescribed benzodiazepines. And now they say, do the benefits outweigh the risks for benzodiazepines? And if it does, then you need to look at each individual and kind of decide if that might be the best treatment for them. But you might consider daily oversight in a methadone program if they are on benzodiazepines. But the risk of overdoses increased on individuals who are on methadone or buprenorphine with a benzodiazepine. And impairment's not clinically significant with buprenorphine either, similar to methadone. Side effects: nausea, vomiting, constipation, the same things we see with methadone. So why did they decide buprenorphine could be written in an office-based setting, but methadone couldn't? So there's something called a ceiling effect with buprenorphine. It's very unique to this medication. The opioid receptor availability decreases with increasing doses of buprenorphine. So opiate effects increase with each dose until at a moderate dose, they're going to level off, so that further dose increases don't really have any effect on the individual. And there's no maintenance benefits above 32. So looking at this graph, if you look at the pictures of the brain scans, and you look at the green area, green is the area that you have availability for buprenorphine to bind at an opioid receptor. So you can see at 0 milligrams, you have a lot of opioid receptor availability because there's no opioids bind. At 2 milligrams, which is the next line down, you can see the green is starting to fade. So at 2 milligrams, you have 27 to 47% of the receptors bound on 2 milligrams of buprenorphine. Then the next line down is 16 milligrams of buprenorphine, and you have 85 to 92% of the receptors blockaded on that 16 milligram dose. So you can see there's almost no green. So you've pretty much maxed out your opioid receptor availability at 16. So going up to 32 on the next line, where you have 94 to 98%, you really don't see a whole lot. There's not a huge difference between 92% of the receptors and 94% of the receptors. So even going up on the dose, let's say you gave them 72 milligrams for some reason, there's nowhere for them to bind. There's no opioid receptor availability. So you're not going to see any changes. They're just kind of wasting the medication. So that's kind of why we say typically our clinic maxes out about 16 milligrams of buprenorphine for an individual. We don't see any benefits of going up to 24. So the max we usually write for is 16 because we like them to use psychosocial supports for any further help, because we don't see any benefits. So when you see medication, so buprenorphine for the last couple of years, and I'm sure it will continue to be, is the most diverted opioid on the street of all the opioids. Methadone, hydrocodone, oxycodone, you name it, buprenorphine is the most diverted medication, meaning someone's taking it either from someone, for getting it from a friend, or they're taking it off label. And most of the time though, because of the ceiling effect, individuals aren't actually getting intoxicated from taking buprenorphine. That's not why it's diverted. That's not why people sell it or buy it. The reason people sell and buy it, if they're, for example, going to see a family member and they told their family member they were in recovery, they've been sober for 2 months or 3 months, and they show up at mom and dad's door. If they were using heroin, they would need to use heroin every 4 to 6 weeks to mitigate any withdrawal symptoms. But they can take 2 to 4 milligrams of buprenorphine and be fine for the day and seem like they're sober. So people divert because they're trying to treat their own withdrawal symptoms. They're trying to treat themselves without going to a provider. So buprenorphine is not diverted to get intoxicated. Buprenorphine is diverted because they're trying to mitigate their own withdrawal symptoms. So that's kind of why we cap our clinics around 16 milligrams, because usually that third film or fourth film, they don't really need it. They're giving it to a family member or friend who needs to get sober but can't for some reason, or they won't see a provider, so we just don't see any need for that. So that's how we decrease diversion within our center, along with all the other things we do, which include urine drug screens and things like that. So that's really, the ceiling effect is very unique to buprenorphine, and I think it's one of the most important things about that medication. So does it work? So there was a randomized controlled trial in Sweden. They looked at 40 patients who had over a year of heroin addiction, and they did not meet the criteria for methadone. Buprenorphine at 16 milligrams was one group, and placebo was a second group. Both groups had intensive psychosocial services, which included cognitive behavioral therapy, weekly individual sessions, 3 weekly supervised urines. And the outcome showed 1 year retention in treatment. That's what they looked at as their endpoint. So at the end of treatment, if you look at the top line, that's your buprenorphine control or buprenorphine group, and then the control group kind of dropped off. So after 1 year, 75% of the buprenorphine group remained in treatment versus 0%. So all of the placebo group had dropped out. And those on buprenorphine remaining in treatment, 75% of those had a negative urine drug screen for illicit substances. But in the control group, which is your placebo group who didn't get medication, 4 of the 20 patients had died by the end of the study. Well, there was no deaths reported in the buprenorphine group. So treatment does work. How do we select individuals to go on buprenorphine? That's that important. Do they have access to a waivered physician, someone who can prescribe for them regularly? And do they have access to a counseling center? And people typically do better on buprenorphine if they have a mild level of social support available to them. Also, if they have multiple medical comorbidities, you might want to put them on buprenorphine because of the decreased drug-drug interactions. And again, that concurrent chronic pain, you'd want them on buprenorphine or methadone, but not naltrexone, because they might need to take medications for their chronic pain, and those medications wouldn't work on naltrexone. So there's a lot of stigma surrounding methadone and buprenorphine. Things you hear are opiate use disorder is a moral weakness or willful choice. Why don't they come off their medication right away? Which is a huge question and stigma is, if they get better, why don't they come off of it? Well, it's a medication like any other. If they had diabetes, you don't ask people to come off their insulin. Same thing with methadone and buprenorphine. We're looking at long-term treatment and goals. And a lot of individuals say they're substituting one drug for another. So the stigma behind it being a chronic illness, the misconception that opiate use disorder is a moral weakness or willful choice. Many in the recovery community believe that recovery depends solely on willpower apps to abstain from all opioids, and that includes methadone and buprenorphine. But if you're treating it just like you would any chronic illness, does someone on insulin who would we withdraw their insulin because we feel like they were stable? No, we would allow them to continue to take their medication. As long as they're not using any illicit things, which is things not prescribed to them, then we consider them in recovery when they're on methadone or buprenorphine. They are in treatment, they are in recovery. Even if they have a relapse, they're still in recovery. And working towards recovery. So yet again, back to someone with diabetes or hypertension who are supposed to be on a specialized diet. We use the word relapse, but I don't think I've ever had anyone come in who ate pecan pie over the weekend for their diabetes check and say, I relapsed on pecan pie, which they shouldn't be eating in the first place with their diabetes. We don't have individuals do that. But people come in and we do that with drug use. We assume that they need to be completely off medication or, there's no relapse. Sometimes there's relapse and recovery, just like there is with your other chronic illnesses. We just use different terms for them, but that's one example. Many residential services force patients to taper off medications as a condition of treatment, which is not a good thing. In the state of Michigan, we're one of the few treatment centers that allow individuals to continue to be maintained on their methadone while they're in treatment. There's 2 or 3 others that I'm aware of. Many counselors even consider taking medication a character weakness. There's a fear of being ostracized of mentioning medication in mutual support groups. Narcotics Anonymous believe medication for opiate use disorder is contrary to their philosophy. So typically there's things called Methadone Anonymous you can go to where you might feel more comfortable if you're on the methadone or buprenorphine. NA chapters typically exclude people taking methadone or buprenorphine from holding leadership roles or attending meetings. So a lot of people get, well, let's just taper off. Why don't you come off your medication? Well, numerous studies demonstrated a greater than 80% relapse rate over time when comparing methadone maintenance to tapering. Similar rates of relapse are now reported comparing buprenorphine maintenance to tapering. So you can see a rapid return to drug use if you were to taper them prematurely. So here's an example of methadone maintenance versus a taper. So this looked at methadone maintenance versus 180-day psychosocial detoxification. So you had the individual, everyone was on methadone at the beginning, and then some people were maintained, and then the other arm of the trial did 180-day detoxification, or they were removed from their medication. So they all had, so the individuals who were on the 180-day, or the methadone maintenance group had psychosocial services 2 hours a week, versus that 180-day methadone detoxification had more services for therapeutic and counseling. They had 3 hours of psychosocial services with 14 education sessions. They had a 1-hour cocaine group, and their dose reduction began at 120 days. And what you'll see is, if you look at the chart at 120 days, is when individuals started leaving the study in the 180-day methadone detox arm of the group, that solid line. They just all of a sudden plummet down at 120 days when they were the detoxification started. So we look at increased treatment retention by maintaining individuals on methadone. Here's the same example with buprenorphine maintenance versus taper. There was a 14-week taper after 6-week stabilization period, and the taper lasted 3 weeks. And if you look at the end of the trial, only 11% of the taper group remained versus 66% of the individuals maintained on buprenorphine still remained in the study. And of those, only 35% of the taper group had negative urine drug screens for opioids versus 53% of the maintenance group were negative for opioids in their urine drug screens. So you see that tapering is less efficacious for individuals on buprenorphine also than ongoing maintenance. So we do like to keep people on their medication unless they are requesting a taper, or we see them doing really well and they're asking to start to taper down. Substitution. So in Europe and Australia, they use the term OST, the opioid substitution treatment. The terminology is misleading to patients and significant others. So methadone and buprenorphine are actually treatments for opiate use disorder. That's why we're trying to get away from the word MAT, medication-assisted treatments, and move toward the term medications for opiate use disorder. We're trying to kind of change our change our wording of things and how we refer to things to make it more of a chronic illness in terms of how people look at it and associate things with it. So there's one thing is you need to make a clear distinction between physical dependence and addiction. So individuals who are on methadone or buprenorphine and they're maintained on it, they're taking their medication as prescribed. Some people, I've heard that people say, well, they're now addicted to methadone, or they're now addicted to buprenorphine or Suboxone or Zubsolv, or whatever form they're on. Well, they're not, as long as they're not, so addiction is not just being on a medication. Addiction is all of the things that surround it. So it includes all of the behaviors associated with it. So it includes, if you look at the DSM-5 criteria for opiate use disorder, you look at things such as, are the individuals attending things they should? So if their child has a recital, are they going to that recital? Or are they missing things in their family life? Are they showing up to work every day? Or are they calling in sick all the time? So if they're showing up to work, they're engaged in their family life, they're doing everything they should do, they're just taking this medication, that's not addiction. They are physically dependent. So for both people who are physically dependent on medication and for addiction, if you withdraw the medication in both types of patient, you're going to see withdrawal no matter what. So they might be individuals who are not engaging in all the behaviors associated with addiction and opiate use disorder. They're physically dependent on their medication, but they're not addicted. They're not addicted to their medication. They're just physically dependent. So it's the same with individuals with chronic pain management. If they're being prescribed Norco on a regular basis, if you withdraw that Norco, they're going to have withdrawal. But as long as they don't engage in behaviors that they're not showing up for things, they're not doing everything in their home life and their work life they're supposed to, then they're physically dependent. They're not addicted. They're just physically dependent on that medication. Methadone and buprenorphine maintain patients with negative urine drug screens and no other criteria for opiate use disorder are physically dependent but not addicted to their medication. So that's very important. So when you look at studies to kind of get out of the idea that you're substituting one drug for another, there was a study evaluating cerebral phosphorus metabolites, specifically phosphocreatinine, phosphodiesterase, and phosphomonoesterase in opiate-dependent polydrug abusers in methadone maintenance treatment. And higher levels of phosphocreatinine indicated higher metabolic rate and better cerebral perfusion. So you want higher levels of the PCR, and higher levels of the phosphodiesterase and phosphomonoesterases indicated higher membrane turnover, therefore less stability. So this was a study that looked at metabolic profiles of two different treatment groups, one who was 39 weeks in treatment with methadone and one at 137 weeks in methadone. And what it showed is you had nearly normal metabolic profiles in long-term methadone maintenance patients. So that suggests that prolonged methadone maintenance is associated with improved neurochemistry. So when you look at the graphs on the left, the one that's completely shaded in on the left is 39 weeks. The middle bar of the bar graph is 137 weeks. And the controlled arm, or the one of individuals who are not opiate dependent on methadone, just normal control, not opiate dependent, is your far right, or the one that's white. So if you look, the first one is the phosphocreatinine. You want it to be increased, similar to normal. So you can see that the longer they were maintained, 39, it actually went up to 100, when it went to 137 weeks, you actually had closer to normal levels of the PCR. And then if you look at the bottom two for PME and PDE, you actually saw them decrease. So you have more stability and less turnover. So you saw improved numbers, and they reflect improved cerebral blood flow and metabolism. So we were trying to get them closer to that white graph, and longer term treatment with methadone actually drove their neurochemistry closer to normal. So it's really a treatment rather than a substitution. It's a more accurate term. The last medication, Naltrexone, this is an opioid antagonist that binds to the opioid receptor, and it actually completely blockades. So this is like a long-acting naloxone, but if you want to think of it that way, it binds to that opiate receptor and doesn't let anything else bind to it. It's also Category C in pregnancy. You actually see an impact on the midbrain dopamine release at the VTA, the ventral tegmental area, nucleus accumbens. So you have actually, because some people say, well, how does it work? Well, that's how you decrease the rewarding properties, and you see decreased usage also outside of the blockade. This can be used for both opioid dependence and alcohol dependence. This is a once a month, it can be written two different ways. We typically use the Vivitrol, which is a once a month injection, but Naltrexone also comes in an oral tablet form. I think the brand name's Brivia for it, but you can also write for both. It can be used for both opioid and alcohol dependence. The biggest thing with this medication is you have to be opioid free for 7 to 10 days. It depends, the length of time you have to be opiate free for depends on what opioid you're using, if it's long or short term opioid or long or short acting opioid. So it's really hard for individuals to be sober and not use opioids for 7 days, because they're going to have to go through withdrawal symptoms and things like that. So they have to be completely through this detoxification process prior to initiation. So individuals who are trying to initiate Vivitrol, who are opioid dependent, outside of a detox residential center, they have a really difficult time not using. That they're at home, they continue to think about using, and a lot of times they can't get that good 5, 7, 10 day of abstinence from opioids. So typically a good place to initiate Naltrexone or the Vivitrol injection is to initiate it when they're inpatient. So they've gone through the detoxification, now they're going through residential treatments center. If you give while they're inpatient, it's a much easier way for them, and they'll much more successfully be able to initiate the Naltrexone. And there's no physical dependence on Naltrexone. So Naltrexone's an opioid agonist, or opioid antagonist. So you kind of need to realize that it binds and it doesn't activate that receptor, so you don't get any physical dependence. If you have active hepatic disease, that might be the only time you might not want to give Naltrexone. So you order liver function tests prior to giving the injection, and making sure they're less than 3 times the normal. Common side effects are nausea, headache, and injection site reaction. One thing that's different than from methadone and buprenorphine is if you try to reinitiate opioids in a Naltrexone, an individual's been on Naltrexone for a long period of time, you have an increased risk of overdose. So when you're on methadone or buprenorphine, you're getting an opioid. So if you give them an opioid on the side, they actually might not really feel the effects, they'll need increased. Well, it's the opposite when they're on Naltrexone. When they're on Naltrexone, if they stop their injection and they try to use, let's say they were using 2 bags or $20 to $40 of heroin a day prior to the injection, and they go back to what they were using before, they're more likely to overdose because their body has lost the tolerance to any type of opioids. And that's why you see most overdoses occurring either one, when they're leaving a residential center and they're not on any medication and they try and use what they used before they lost tolerance. So leaving a residential center, you see it when they're leaving jail. So if someone's been incarcerated for a month, 2 months, 3 months, and they haven't had opioids, and they leave jail and they try to use the same amount they did before, you see high overdose rates in individuals who are incarcerated who are in treatment. And same if they stop Naltrexone and try to use afterwards. Patient population that does well includes those who there's an external incentive to comply with treatment. So healthcare professionals, business executive, probation, parolee officers. Treatment selection. So if they have no access to methadone or buprenorphine from a physician, then this might be a good option for them, because you don't have to have any special licensure to prescribe Vivitrol or Rivia. If the patient's currently abstinent and they have frequent relapses and or cravings, but they're abstinent, they're not using. So people in drug treatment court, recently incarcerated individuals will do well on Naltrexone. Patient population that does well includes those for whom there's an external incentive. Oh, I said that. Recent detoxification from an opiate agonist therapy. So if someone was on methadone or buprenorphine and they're trying to slowly titrate down and transition into non-opioid based forms, you switch them to Naltrexone. That might be a good option because it buys them time, where if they relapse, they've got that on board to cover them. They can't have any surgical interventions planned in the future, or in the close future. If it's 3 months down the line, it's fine. You just have to work with the surgeon prior to the injection date, prior to the surgery, and patients with a history of compliance with treatment. So key points: addiction is a chronic brain disease, no different than any other chronic disorders. So we need to treat everybody as if it's a chronic disorder and they're going to be in treatment for a long time. All treatments work for some patients, but no one treatment works for all patients. So just because they didn't do well on Vivitrol or maybe even Suboxone and end up on methadone, it's a treatment failure. It's not a patient failure. That medication might not have been right for them. So all treatments are going to work, but the question is what's going to work for one person might be different than what's going to work for another. So you have to kind of figure that out. And there's a lot of overlap in the treatments. So, someone who could be potentially a good candidate for buprenorphine might be a good candidate also for methadone. There's tons of overlap. So you have to work with the patient on what would be the best medication. SUD, substance use disorder in general, has a pretty poor prognosis. So we really want to use all the best treatments involved in it to have a better outcome. And treatment is most effective when psychosocial elements and neurobiology are considered and addressed. Okay, and I'm done.
Thank you so much, Dr. Romanik. Matt, did you want to start the Q&A? I see we do have a few questions here.
Yeah, I'd love to. Thank you, Becca. So, and thank you, Doctor. I just always very informative when I've heard you speak. So I appreciate your time. I have a few questions here for you. So if I'll try and read through these from Janine. Why would some clinics allow their clients to go above 124 milligrams of methadone, sometimes without an EKG and a peak and through?
Peak and trough is probably what.
Yes, it's my mistake. She did write that.
So every clinic is different. We typically require, one of the things we look for when someone's on methadone, methadone can put them into torsades at higher doses. It's a cardiac abnormality. So we typically, we don't put a cap on methadone. SAMHSA doesn't recommend that. So there is no specific dosage that a clinic has to cap a dosage on. So if someone is going to hit 150 milligrams at our clinic, that's when we require an EKG, and we require them every 3 months for an individual maintained above 150 milligrams. When we consider a peak and trough, we only look at a peak and trough when we're considering a split dosage. So with methadone, and I know this wasn't in this presentation, but methadone's dosed classically once a day, maybe twice. So that's when we do the peak and trough, and we're looking at the twice a day dosing, the split dosing. So when someone takes their full dose in the morning, after they've been stable at a dose for a period of time, they have a nice steady state in their blood levels. Now, if someone is on another medication, so a lot of the HIV medications or medications for hepatitis can cause individuals to metabolize methadone. So what might feel like 150 milligrams in one person might only feel like 20 milligrams on another, depending if their metabolism's quicker. So how we monitor that is with a peak and trough. So we look at their peak plasma level concentrations of methadone and their trough, their low levels. So if they're bottoming out, it's less than a 2-to-1 ratio, then we're going to look at a split dose, because that way we know that their methadone levels go up and they don't bottom out completely. You can go ahead and give them another dose to keep them up through the day. We do this most often in pregnancy, and we don't do peaks and troughs during the pregnant period, because what it showed is in the 3rd trimester of pregnancy, at the very end, about 36 to 38 weeks, their metabolism picks up so much, even without medication, because they're growing the fetus, they have different metabolism. They show that the methadone only lasts for about 8 hours after their dose in the end of the 3rd trimester, the study shows. So we do split dosing in pregnant females without the peak and trough. But that's the reason we would order a peak and trough, is if we were looking at split dosing, or if someone said their dose wasn't holding them and they continue to go up, up, and up, we'd want to see if they were rapidly metabolizing their methadone.
Very good. Thank you. The next question from Karen here. A person said she wanted to keep using Suboxone, but was taken off, was told that it was not allowed long-term under her Medicaid. Can you explain what she meant?
I'm going to tell you that I would have had her go back, call Medicaid, because that's incorrect. Medicaid doesn't even require prior authorization, and there's no cap on the amount of time they can be in treatment. They don't cap the medications. Almost 90% of my population is Medicaid, and we have people in long-term treatment with buprenorphine. So I would maybe do a little bit more digging to see, reach out to her Medicaid with her in the room, talk to them, talk to who's prescribing and saying this. But classically, there's no cap on treatment.
Very good. Thank you. from an anonymous attendee. Is there any blood work that is required before prescribing methadone and or buprenorphine products?
Yes, so for methadone, it's required. For buprenorphine, it's recommended, but our policy at our clinics is that we do them anyway on both. So for methadone, the federal government requires that you do a CBC, or complete blood count, a CMP, which is a complete metabolic profile that includes your liver enzymes, your kidney, electrolytes. It includes a syphilis test, hepatitis B and C, in a urinalysis. So that's for methadone, what's required by the Fed. So we do order all of that, and we do the same thing for also our buprenorphine clients. And if someone is requesting, we can offer HIV, any type of STI or hepatitis screenings too. So yes, it is required for methadone, but it's not required for buprenorphine, but we highly recommend it.
Okay. The next question is the urine drug screens. How, in a clinic setting, do you manage individuals who might be using other opiate products on, aside, legal opiate use, besides their MAT medication, particularly methadone or buprenorphine? How can you measure for or assess for that occurrence?
So I guess just to clarify the question, are they looking at if they're taking methadone or buprenorphine, how we verify it with the drug screens?
Or how do we know that they're not chipping with some other kind of opiate or using some other kind of opiate on top of the MAT medication?
Oh, okay. So I mean, our urine drug screens test for all that. So when someone gives a urine drug screen, it tests for all opiates. So it tests for hydrocodone, it tests for oxycodone, it tests for morphine type products. It does test for all those opiates. And then we also test the methadone level, or make sure there's methadone in the urine drug screen. But one of the big things you need to test for with both methadone and buprenorphine is not only is it in the urine, but do you have metabolites of it? You have to have metabolites. You can actually not have any methadone in urine, but have methadone metabolites, and it's still a good specimen. Metabolites are important. So if an individual wanted to divert medication, and let's say they weren't taking their methadone as prescribed or weren't taking their buprenorphine, and they wanted you to think that they were taking it so that you would continue to prescribe for them, what they can do is put a small piece of methadone or a small piece of buprenorphine, or pinch a little bit of methadone into the cup, and it'll show positive for methadone, but it won't have the metabolites. The metabolites, the person needs to take it. It needs to be processed by the body to create those metabolites. So you need to make sure when you're doing your drug screens that you're testing, along with the methadone, you're testing for metabolites in both methadone and buprenorphine to make sure they are taking their medication. You need to make sure your urine drug screen tests for all the opiates on the market, or most of them at least. We also test for benzodiazepines, cocaine, alcohol, PCP. We have a very big panel of, we test for all illicits pretty much every time. And it's every time we do a urine drug screen, it's not just here or there. So those are important to test for.
Thank you. The next comment from Aaron is could you reinforce about the dangers and risks involved with using alcohol and buprenorphine?
Yes, so the same, it's benzodiazepines and alcohol are both respiratory depressants. So anybody who's drinking on methadone or drinking on buprenorphine or using a benzodiazepine or any type of respiratory depressants, a barbiturate, you are not supposed to mix it with methadone or buprenorphine. So it's really the combination of benzodiazepines, alcohol, some type of depressive agent with the methadone or buprenorphine. So we highly recommend against it. If someone's continuously drinking in our clinic, we do daily breathalyzers on them before we give them their medication. And if they're blowing positive, we won't give them their medication that day. And we highly encourage them to go inpatient for a detoxification for alcohol. But it can cause overdose and death, respiratory depression.
Thank you. Next question, doctor, is for individuals who book into a jail using MAT medications. Can you talk about some of the timelines and how incarceration might affect the medications that might be available or appropriate for them?
So if they were on naltrexone, that would be, naltrexone's kind of its own class a little bit, it's a little bit different. If they go a couple, week, 2 weeks, they're not, and let's say they were due for their injections 2 weeks into incarceration, but they don't get assessed for 3 to 4 weeks, they won't have any withdrawal, so there'll be no, because there's no physical dependence. But for methadone and buprenorphine, it's different. So individuals, if if their medication is withheld from them for a certain period of time, usually 72 hours or so, you're going to start to see withdrawal symptoms quite significantly. The problems with methadone specifically is if they're withheld from their medication for too long, their levels go down and they will need to be reinitiated. So an individual who hasn't had methadone for 3 days, their dosage has to be decreased by 50% of the dose. And an individual who hasn't had methadone for 4 days has to be restarted completely at the low dose, which is 20 to 30 milligrams. And then they have to kind of go back to trying to achieve that stability that could take up to 3 to 6 months to achieve. So if they're on a dose of 110 milligrams and they're doing really well, now all of a sudden we've bottomed them out and they're restarting at 30. We've got to get them back up to that therapeutic dose, because if they're released, they're going to still have all those cravings and things they had from before. So our goal is to keep that steady level. So with methadone, typically we'd like to see them within 3 to 4 days, hopefully within 3, so that we can dose them without decreasing their dose. Buprenorphine's a little bit different. You can achieve steady state probably 3 days tops. So individuals on buprenorphine can reach their steady state buprenorphine level quite easily. But the problem with withholding treatment is they will go through withdrawal, and then you'll have to reinitiate it, which withdrawal is very uncomfortable for individuals. So we try to avoid that. But it's methadone is the one where we got to get it quite quickly to maintain their stability.
Absolutely, thank you. Just another medication that we didn't talk about, but it is an important one, is providing naloxone kits for individuals involved in treatment.
Yeah. So we recommend anytime someone begins in treatment, a naloxone kit. We dispense them directly at the clinic. So on admission, your very first day, we dispense you a naloxone kit to keep with you. And then if for some reason you use it, or it's used on you, or you use it on a friend, you just have to ask for another kit and we dispense them freely. If you're writing it from an outpatient clinic as a PCP, you're writing buprenorphine, not methadone, hopefully, just buprenorphine products, then we recommend you also give them a script for naloxone with their buprenorphine script so they can fill it on day one.
I would love to keep going on, doctors. I can run on at the mouth here pretty comfortably. So, but again, I really appreciate you carving out some time. I want to turn it back over to Becca, though, for some closing comments, and just express my personal appreciation for your time and expertise today in this really important area. So thank you, doctor. And Becca?
Yes, absolutely. Thank you so much, Dr. Romanik, and everyone else who joined us here today for this OT Community of Practice Lunch and Learn. We really hope that these lunch and learns are pertinent to your work and informative. A recording of this webinar will be posted on the CBHJ website and YouTube page within the next week or so. So we will also send a copy of the slides and related materials to all the attendees as soon as we can. So please keep an eye out for future events and those other documents that will be coming out to you. These webinars will be held every other month, with the next one to be scheduled in September. Last, but certainly not least, it's important to us that the content that we share is useful and relevant to the work that you are doing, and we value any feedback that you have. So we would appreciate you taking a moment once the webinar is over to click the link that'll pop up on your screen to complete a brief survey. If you don't receive the link to the survey, please inform us so that we can send that along to you as well. Thank you again for joining us today, and we'll talk to everybody soon.